Welcome to our presentation today on the recent issue of Public Policy and Aging Annual Wellness Visit for the Older Adult, Challenges and Opportunities. This issue was published by the National Academy on Aging Society, the Policy Institute of the Gerontological Society of America, in the first quarter of 2019. Hi, I'm Trish D'Antonio. I'm Vice President of Professional Affairs for the Gerontological Society of America, and I'm pleased to introduce our panels, who include the guest editors of this issue and two authors of articles in the issue. I'd like to start by asking our panelists to introduce themselves. So first we have Sherry Scheinfeld-Gorin.
Hello, welcome. I'm Sherry Scheinfeld-Gorin, and my work focuses on cancer-related health disparities and health services research across the lifespan, with a focus on the older adult. And I am a professor in the Department of Family Medicine at the University of Michigan Medical School. And I also direct the New York Physicians Against Cancer, which is a grant-funded research and training group that works with primary care physicians to reduce health disparities in cancer prevention and screening. And that's in the New York area. I'm very happy to join this webinar with my colleagues. And it was a pleasure to co-author and co-edit the journal.
And Barb Resnick.
Yeah, hi, I'm Barb Resnick, and I was the guest editor for this issue with Sherry, and I am a professor at the University of Maryland School of Nursing and a geriatric nurse practitioner.
And Peter Hallman.
Hi, it's Pete Holman. Welcome. I serve as a primary care geriatrician at the Warren Alpert Medical School, Brown University. I'm also the medical director of our Medicare Shared Savings Program, Accountable Care Organization. Been very active in public policy work with the American Geriatric Society, especially in the area of payment for physician and other healthcare professional services, and I'm past chair of the CPT editorial panel.
And finally, Brian Kaskie.
Hello, my name is Brian Kaskie. I'm a professor in the College of Public Health at the University of Iowa. I also serve as the editor-in-chief for the Gerontological Society Public Policy and Aging Report, and want to thank you all for joining us today.
Thanks, panelists. I would remind listeners that complete bios of our panelists can be downloaded from the GoToWebinar panel. So today's agenda includes a discussion with our panelists supported by the visuals that you'll see to highlight key points of the annual wellness visit publication. A question and answer session will immediately follow our live discussion. So Sherry and Barb, I'll kick it to you as guest editors. Can you share with our audience how you came to the topic of the annual wellness visit?
Yes, so I think that Sherry and I were sort of working together to see where we could build some consistent focuses and approaches and interests across members of the Gerontological Society of America and the Society of Behavioral Medicine, because there's really subgroups within both organizations that were really working on promoting health among older adults. And this came up as really the perfect way for us to be able to do that, to use the annual wellness visit as an opportunity to engage members across both groups.
And it also offers a wonderful opportunity to look through a variety of professional lenses across the service continuum, from prevention to screening and diagnosis to intervention, and as well to clinical research and policy approaches. So it seemed like a perfect opportunity for both groups and for we as the co-editors.
So just to give a little background, I imagine most of you are familiar with the annual wellness visit, and really the purpose of this is to encourage preventive care and mitigate health risks in aging older adults, really looking at age-appropriate and risk-modifying screening and assessments. So, to me, just a really, really exciting area and opportunity to address health promotion. in this slide, you can see the different areas that need to be addressed within the annual wellness visit. We'll be talking a little bit more about this through the presentation. I would refer you to the papers that really go into more detail about what exactly needs to be within an annual wellness visit, and at the same time, what shouldn't be part of the annual wellness visit. For example, I think it's really just important to keep in mind that it is not an annual physical exam. It's an annual wellness visit.
This slide and the subsequent 2 slides tell you a bit about how the wellness visit has varied in uptake across the country and by different subpopulations within the country. So this slide tells you a bit about the overall disparities in healthy aging, which most of you on the call are probably quite familiar with. But as you can see, older adults who are both white and not on this slide, but on other slides that are widely available, as well educated and more affluent, are more likely to experience good health than those who are not. So conversely, those who are African American and Hispanic, less well educated, less affluent, and are less likely to report good health. In fact, one widely reported data point was shared by Chetty in that between 2001 and 2014, the top 5% of income among Americans gained almost 3 years of life expectancy, while the bottom 5% made no gains at all. On the next slide, we look more particularly at the annual wellness visit and where it's most available or where the uptake has been highest. And in many ways, it reflects the same kind of disparities as you see in healthy aging. The annual wellness visit is offered at about half of primary care practices. That means that about half of primary care practices are offering it. It is, of course, available to all primary care practices. And it's less likely to be offered in practices that served underserved populations, that serve the same kind of disparate lower income populations that we discussed in terms of healthy aging. And importantly for those who practice, and Peter's going to speak to this a little bit more later on, is that practices that offer annual wellness visits have generated more revenue than those that do not. So there is an incentive for doing the annual wellness visit. And the reimbursement is somewhat higher for Medicare for the annual wellness visit than traditional wellness visits, but it also has the potential to widen resource gaps because those who are already receiving it are more likely to continue to receive it than those who have not. And the next slide highlights some of these differences a little bit again, and that is in looking at the trends overall in the adoption of the annual wellness visit. Those who are white, urban dwelling, higher income, and received a previous visit are more likely to get the annual wellness visit than those who are not. Those who are less likely, again, are those who are non-white, African American, and Hispanic. Medically complex, many comorbidities, dually enrolled in Medicare and Medicaid who tend to be more underserved and poorer individuals. So we can see that some of these trends in health disparities emerge across healthy aging to the uptake of the annual wellness visit and the delivery of the annual wellness visit. I'm going to shift.
Jerry, you know, this is
Go ahead.
This is Pete Holman. I think it's interesting that there's the slow growth and the differential growth in the type of practices. You know, I think the practices that are safety net practices that are trying to take care of a lot of dual eligibles and oftentimes in socially disadvantaged communities are just trying to keep their head above water so much of the time that they really don't have time to focus on this particular service. I think in some of the other practices, it's something that's different than what they've done for years. You know, you sort of have the sick visits and the routine follow-ups and your annual checkups, and this is different. And as you said, it's not an annual physical, so it's taken a while for people to really understand what it is. And because it's just a Medicare benefit, it's not a service that you see for your other types of patients, and most people are not just caring for the elderly, it sort of makes it difficult to get it into your routine. So we'll talk more about how it's a great opportunity, but I think that's some of the reasons why we see a slow uptick.
And you're pointing to some structural differences too, which suggest where there are some data that suggests that where there is a higher proportion of primary care physicians or more Medicare beneficiaries per primary care physician, the uptake is a little bit higher. Also in some accountable care organizations or those that are using the Medicare electronic health resource incentive program. So you're suggesting there are practice variations that influence uptake.
That's really quite true.
Absolutely. And I would add to that the practices increasingly are being embedded within these larger health systems. And so from a public health perspective, we're very excited to see the introduction of these annual contacts. And to your point, they aren't medical exams or physical exams necessarily, but surveying all the other elements that are critical to health. And having these systems uptake it at a, if you will, a centralized process will encourage these other practices to, if you will, jump on board with this.
And also, as you see on the slide, the uptake has increased from 2011 to 2015, with the percentage of Medicare beneficiaries receiving the annual wellness visit increasing from 7.5% in 2011 to 15.6% in 2014 and 18.8% in 2015. So the trend is upward, which is important.
Absolutely.
Maybe Barb would like to speak a bit about the health promotion opportunities.
Yes, so the thing that is so exciting to me is that the annual wellness visit really allows us to be very innovative and really think out of the box when you think about providing this for individuals from 65 to, I'm going to say 105, because that's my world. And these are all of the different areas you can address depending on the needs of the patient. And when we talk about disparities, I think it's also important to think about the annual wellness visit is just as important for somebody who's 105 as it is for somebody who's 65. We just may look at different things. For example, smoking may be more relevant for some of those on the younger end of aging. Falls, certainly important to all, but they might be more important to the old. Incontinence may, again, hit the whole aging continuum. So it really, really varies. We look at cardiovascular screening and heart healthy behavior. That can be important to somebody at the end of life as well as prevention. And likewise with depression, alcohol, driving can be built into the annual wellness visit, safe sex, cognitive issues, and we'll talk a little bit more about that, but it's a wonderful opportunity to look at cognition across the aging spectrum, physical activity, and immunizations.
You know, just to add to this, in the policy space, we also have had initiatives in the area of elder abuse and neglect. Mm-hmm. And we had a meeting yesterday where we talked about what mandatory reporters are typically required to do, i.e. emergency room physicians or general practitioners. And these screening visits can serve as a vehicle to also explore any potential elder fraud or abuse or neglect that might be going on.
Absolutely. The other thing that's important with the annual wellness visit to think about is that once we do come up with a plan, which is part of the goal, kind of a health promotion plan, it's important to think about ways to help that individual change behavior if that is the goal. It might be increasing exercise, decreasing smoking, altering some dietary behaviors. Whatever it is, it's thinking about some motivational interventions. And these are just a few quick tricks of the trade to really provide that verbal encouragement and reinforcement to patients throughout the year as you're doing your other visits. And as we need to do in aging often, it's using ourselves as that reward, tying the behavior to outcomes. For example, wow, your blood pressure's decreased because you really have cut out salt, or whatever the behavior might be. So once you do go through your annual wellness visit, the goal is to come up with a personalized health plan. And this gives us an opportunity to look at what is important for that patient. We talked about the challenges to doing an annual wellness visit. One thing I didn't hear mentioned by everybody else was the fact that some of the challenges patients themselves. People are used to going to providers for a reason. They sit down in the chair and they want to bring their medical problem of the day. People don't really understand the value and the importance of preventive care. So we have to make it a useful visit and help people come up with goals that are going to be useful to them and important to them. And that's a really wonderful opportunity of that personalized health plan. This slide just sort of reiterates what we've been talking about, and the lack of uptake, the lack of numbers of people that are using this preventive service. And hopefully, as we go through this, it will encourage others to build this into your practices.
And that's, Barb, that's exactly what we're trying to do when we care for folks. And I think the nice thing about the last slide is that you do see the majority of the population is getting some preventive services. Maybe that's only a flu shot, but they are getting some care that is very important for their well-being. I think not only are we trying to move from sickness care to promoting health, but we're trying to address the health of populations. And one of the things that we're seeing is that the practices that are organized, such as being advanced primary care, or part of organizations that have shared savings contracts with Medicare or Medicare Advantage programs, are particularly more likely to engage in the annual wellness visit program because they see the benefits that it has to the population of patients they care for. But I have to say, an awful lot of people in geriatrics, they say, well, we really need, our sweet spot is focusing on that multi-morbid patient that has multiple chronic conditions, that's always at the risk for hospitalization. We've got to double down on all the care we do for them and keep them out of the hospital, keep them out of the emergency room. And while that's true, you did nicely point out that the annual wellness visit has features that are important for people, whether they're 65 or 105. I think the other thing for a lot of physicians, and if they are just in a practice by themselves, although that's a shrinking breed, there's a lot of things in the annual wellness visit that are not sort of the things that they're used to, such as a health risk appraisal, and some of these other type of concepts. Even sometimes activities of daily living are a term that people may know conceptually but don't necessarily articulate. But the annual wellness visit gives us a great opportunity to really get a good look at the patient and oftentimes bring in other members of the healthcare team. Some organizations bring in a pharmacist to do a very careful and thoughtful medication review and use this preventive exam that's free for the beneficiary to address that particular area. Some folks use it as a good opportunity to address advanced directives and patients' preferences for care as part of the annual wellness visit. And there's now even a medical service code, a CPT code for advanced care planning that pays very similar to the annual wellness visit and very similar to a category level 4, a follow-up office visit exam that can be used and can be performed by the team. So I think there's lots of ways to build this into a system of seeing patients and addressing a lot of different needs. It is quite feasible once you get organized. And as Sherry pointed out, it actually is somewhat of a financial boon for the practices that are able to get organized. You can, in a relatively short period of time, provide these preventative services. You can address advanced care plans, and if you spend about 16 minutes on the team providing the advanced care planning stuff, you get paid for that service. And in addition, if you have allowed yourself enough time, you can address the complaints that Barbara mentioned, that the patient has problems that they want addressed while they're at the same visit. They don't want to come back another time. So you really can bill for 3 services that are major, and then there's other less major preventive services that are, paying on the range of $15 to $20. And by the time you're done, it really is very helpful to the patient to have all their needs addressed, to have important things that oftentimes get overlooked. They may have the opportunity to see different team members with special expertise in either prevention and education or in pharmaceutical management. And the practice does very well also. And then finally, a lot of the organizations are using this as a great opportunity to make sure all their diagnoses are addressed, especially those diagnoses that affect risk adjustment factors that are used in shared savings programs in Medicare or in other quality and value-based payment programs. So I think this is really something that's great for the patients, but is also great for the practice.
And just to abstract from there a little bit, is this is also great for the public, because what these visits do is they open up the individual to meet a variety of professionals who can assist them as they continue to age, both successfully and with challenges. So a wellness visit that brings in a pharmacist or a therapist who can help the person with, let's say, continuing to engage in leisure activities while they're still, 65 to 80 years old. That's what one of these visits can encourage to happen. And as more older adults see the value of that, I think you're going to see a greater demand. Another opportunity here for the public are caregivers of older adults who come in. We're increasingly relying on informal caregivers. The AARP initiative with the CARE Act is requiring, or at least suggesting, that hospitals become more attuned to not only the older patient, but their caregiver as well. So these visits can provide a platform for that sort of relationship building. It's very exciting.
Brian, I do want to point out that I practiced in a small group, but I was always the only person in the office at a given time, except for a secretary. I didn't even have a medical assistant, and I could do these too. So it's great if you're part of an organization, but you can also, as an individual clinician, whether it's a nurse practitioner, physician assistant, or a physician, can do these. And in fact, they really don't even require that a physician or nurse practitioner do them. You can have your, if you are fortunate enough to have some other staff supporting you, it makes it even easier.
Yeah, so on the side of implementation, really, this is it can be a team project, and it is helpful to have it be a team project to make it really efficient. And Vicki Simpson in her article talks about the use of NPs doing annual wellness visits. It's a big part of what I also do within my own practice. And at the same time, there's some other things that are recommended to help facilitate a practice to implement the annual wellness visit. Some of it is a commitment and a focus on prevention. So you have to believe that prevention is helpful, addressing some of these issues, talking about driving, talking about falls prevention, diabetes prevention. You have to believe in it, and the practice has to commit to it. The other is designing effective workflows. It is helpful. I mean, we can do the whole thing ourselves, or we can also use other members of the team. It might be a med tech to get weights and blood pressures, which are a couple of the things that you would do within an annual wellness visit, or certainly can do. It might even be having another staff member go through some depression screening or cognitive screening. So there's different ways to think about it. And then, as I said, it's critically important to make it worthwhile for the patient, because otherwise they're not going to want to do it. And I know I've had many patients who come in for it and it's like, what is this and why am I here? And then lastly, it's that very important focus on behavior change throughout the year. These, and I thank Dr. Tiffanini for this slide and reflection of all the different members of the team that can be involved in this process.
So as this slide suggests, evidence-based tools are key to the visit. As you've learned from some of our other presenters, the annual wellness visit includes a health risk assessment, which I'm going to talk about in just a minute, as well as a personalized prevention plan services, as we discussed just previously. And the health risk assessment is critically important because it helps to evaluate the health status indicators and the risk factors for a variety of diseases, including cardiovascular disease, cancer, as well as cognitive decline and diabetes. So the mandated health risk assessment that I will discuss in just a minute, I will discuss one example of it in just a minute, is a critical part of the assessment process. The health risk assessment that I'm going to discuss is from my own health report project. I'm going to be calling it the MORE project. And as you can see at the bottom, there's a URL that you can follow to look at more about my own health report. And this is a tool that's electronic or paper-based and includes a screen of about 13 health behaviors and psychosocial issues, including tobacco use and stress, alcohol use, and so on. You'll see some findings on these issues in just a few minutes. And it provides follow-up questions for positive screens. And the assessment looks at the patient's readiness for change and also helps the patient to identify his or her most important topic for change, or what he or she would like to change first and then subsequently. It allows for automated patient and clinician feedback, and it allows for smart goal setting. We've talked about the importance of goal setting to behavior change, and the SMART goals are specific, S, measurable, achievable, realistic, and timely, the T. This is an example of my own health report that would be completed by the patient either electronically or on paper, and a summary of this form or this document would be provided to the provider and would be used as the basis for goal setting, again, the SMART goal setting, with the clinician so that behavior change can result from this assessment. On the next slide, you'll see that we conducted a very stringent and tight assessment of the MORE. And so there was a MORE study of the study tool. And we used a cluster randomized pragmatic trial. That's a trial that responds to the demands of the practice settings across 9 diverse pairs of primary care practices. And we were testing whether they could implement my own health reports. It was really an implementation test. And our outcomes were typical implementation outcomes, which included whether practices would adopt and implement the MORE, how they would implement the MORE, the practice reach of the MORE assessment, that is how many in the practice would actually use the MORE tool, and the effectiveness, the traditional outcome for trials for the MORE assessment. And again, MORE is my own health report. So on the next slide, you'll see some of the findings from this systematic study of the MORE tool, of the implementation of the MORE tool across those 9 practices. And you're going to see 2 sets of findings, one on this slide and one on the other. And these are, so I'll go back to the previous one to start. Did anyone help you set a goal? So you can see that in the case of really pretty much all of these domains or all of these topics, someone did help the patient set a goal to change this behavior. There were two trends in tobacco and smoking and drug use, and the others were statistically significant, meaning that those who participated in the intervention sites, those patients who participated in the intervention sites, were more likely to have someone help them set a goal for behavior change in these areas, like eating and diet, physical activity, tobacco, alcohol use, drug use, stress level, anxiety, depression, and sleep, than those in the control group. And in most cases, the change was considerable as well as statistically significant. Moving to the next slide. Have you made any positive changes? Of course, this is one of the hallmarks of the annual wellness visit, the follow-up from the annual wellness visit, as we've been discussing. And so the more tool, the My Own Health Report tool, was in those sites that implemented the tool. There were more positive changes in behavior, in eating and diet, again, physical activity, tobacco, alcohol use, drug use, stress level, anxiety and depression, and sleep. Not all of these are required components of the annual wellness visit, but they were assessed by our MORE tool. And if you look at the article that we wrote for the special issue, you'll see the comparison of the annual wellness visit components in the MORE tool. And we also suggest as a result that the MORE tool should be supplemented by others. But this is, as you may see, a very effective way to not only assess these needs in patients, but also to help them set goals for change and then to actually make change. As you may see, particularly in diet and physical activity, stress level, anxiety, depression, and sleep, there were significant differences among patients who were in the sites that implemented the MORE tool as opposed to those who did not. In the final slide, I'm talking about the MORE tool and highlighting its use as an annual wellness visit assessment tool. As we've mentioned, as all of our presenters have really mentioned, patients have oftentimes unrecognized or unassessed preventive and chronic care and health behavior and mental health needs. And so a health risk assessment like MORE, and again, a health risk assessment is a critical component of the annual wellness visit, takes planning and time and staff and other resources and commitment, but can be extremely beneficial in changing some of these oftentimes very, very intractable behaviors through assessing them, through setting goals with the patient, and through the follow-up that we've been listing. But it's important that this implementation of the MORE tool, like portions of the annual wellness visits, as we've also discussed, be tailored to meet some of the local needs and the workflow. And these are key to success, not only of implementation of the tool in the annual wellness visit, but also the annual wellness visit itself. So patients and practices can benefit from using evidence-based tools like MORE, and they are actually key to the success not only of behavior change, but also to the wider visit itself. Barbara's going to talk a little bit about these other GSA toolkits.
Yeah, so in addition to something like the MORE, there are lots of, I think, resources and toolkits out there. GSA has two that I think are very relevant to the annual wellness visit. One, the CARE, looking at cognitive impairment and being able to detect early evidence of dementia, what measures to use, how to use them, how to go through the process, how to work with patients. So they're a terrific resource. The other is all of the work on immunizations and what older adults should be getting and how to help them get there. And I think this is particularly timely with what's going on currently with regard to immunizations. But there are terrific resources to help people through that. There's other resources out there. I would say that the American Geriatric Society, we just published not that long ago a terrific resource on driving and driving cessation. So it's reaching out using some of those tools and being able to give resources from those tools to patients as is required within the annual wellness visit. Sherry, did you want to?
Yeah.
I thought maybe, Sherry, you want to touch on social determinants of health?
And I'll be happy to hear some from Brian on this as well. So as we discussed previously, there are a variety of assessment approaches available for the annual wellness visit. But one area that hasn't really been touched on too much, either in the undergirding of the annual wellness visit or even in many of the assessment tools that are available, are the social determinants of health screening, or really the core causes, as it were, of poor health. And so one of our authors in our special issue, in particular, Renuka Tipernini, excuse me if I mispronounced her name for a moment there, wrote a lovely piece with her colleagues on the social determinants of health screening, and really looking at health screening not just from a more narrow perspective, but at a broader level. And she was suggesting that this is an area that we should move forward in the policy arena, in particular for subsequent work for enhanced annual wellness visits in the future. And there are some tools available, as well as some approaches available to address these social determinants at present, although it is an area that is where there's active work going on.
Absolutely. The CARE Act not only encourages caregivers to get involved with this, but also what's happening is health systems are increasingly partnering with members of the aging network. That is the folks who are affiliated with providing nutrition services to older adults, caregiver support services to older adults, home modification, transportation, all these types of services that occur upstream, if you will, or as a complement to healthcare. Well, the health systems are seeing that there's an established network out there of providers who do this, and they're increasingly forming partnerships with them. In fact, in our next issue of the Public Policy and Aging Report, we're going to be focusing on a few of these efforts, both in the nutrition and in the caregiving space. So fully agree that this is another opportunity for system-wide partnerships.
And of course, as you're suggesting, Brian, one of the ways that we can begin to look at this is to do some systematic assessments, as might be found in Prepare, as well as rely to some extent on the existing policy initiatives that are in the works and also in practice, the accountable health communities. And as you see on this slide, the Prepare, or the protocol for responding to and assessing patients' assets, risks, and experiences through the National Association of Community Health Centers, gives a series of core measures of the social determinants of health, as well as optional, and they are electronic health record compatible, which is so critical. We haven't discussed this as much as we might, or as much as we will, how important the electronic health record compatibility of our work has become. And with accountable health communities, as you're suggesting, these linkages among healthcare systems with community services, and through bridge organizations and so on, particularly healthcare systems and safety net systems with community services, are critically important. Not only do they rest on important tools that measure these social determinants, and also measure areas of need that haven't been discussed so much thus far, like nutrition and transportation and safe neighborhoods and so on. But they allow opportunities for moving forward in those areas after assessment. The next slide talks about this enhanced Medicare annual wellness visit. As we discussed in the beginning, the core components of the annual wellness visit are here in the purple. And then this additional social determinants of health is an assessment arena, and then it's an area for intervention, not only in the primary care practice arena, but also in the wider community to bring in those resources as we suggested, and to link those resources, particularly the safety net clinics, are going to be critically important to enrich the annual wellness visit for those notably who are less likely to receive it or who are living in communities where the uptake is not as high. The next slide does highlight this enhanced model again from one of the papers in our special issue. And here, as you can read, in an enhanced annual wellness visit, Medicare beneficiaries would therefore engage with primary care teams to develop that tailored plan that we've talked about throughout this webinar, that moves beyond really the basic lifestyle counseling around, stress management and tobacco and so on, to identify and address social risk factors that contribute to health disparities, like nutritional deficits, living in a food desert, for example. And in this way, the enhanced annual wellness visit of the future may help to reduce disparities in healthy aging, which we saw on the first slide or in one of the early slides, and increase, importantly, longevity for the most vulnerable older adults. And Brian, maybe you want to speak to this final slide about the policy recommendations.
Thank you. So far, this has been an excellent survey of what is going on at both the individual clinic level and then tying it to, if you will, these more system-wide and policy initiatives. And we need to rely a lot on our health systems, both the traditional fee-for-service health system as well as the Medicare Advantage system, because both of them are starting to uptake the utility and they see the value in conducting these visits. And so one policy element that may be something for us to consider and move forward on is to establish a uniform criteria, if you will, or a standard approach to not only what the assessment is going to dive into, but what we can then have it lead to next. So what we're finding is some of these assessments are being done, and then patients are referred for things that, well, may not be what we might consider to be the best use of subsequent health care services. Conversely, we do see that when annual assessments are done, older adults are getting things identified earlier in the progression of the disease, and of course, that's just tremendous. The other thing on the policy level, besides coming up with a standardized approach to the assessment process, and there I again refer to what happens with nursing home assessments. We have a uniform clinical assessment that occurs when people enter the nursing home and subsequent annual assessments from there. I'm not suggesting we do that with the annual visit, but it's something to consider. On the other side, we do have to increase our evaluation and oversight of what's going on with these assessments, especially in the Medicare Advantage space. There has been some suggestion that these visits are serving as a platform, not only to expand the number of providers who are involved in patient care and providing services that are determined to be medically necessary, if not just socially supportive. There's a concern that there is some amount of what we call risk adjustment going on. And what that does is allow for the per person payment from MCOs to be increased. And we're not sure what we're getting for that. It's hard to look at Medicare Advantage data and see where are these assessments leading to. And so as a policy maker, I would be looking into some amount of oversight of what happens when we do all this great work.
Brian, it's interesting. I've worked with Blue Cross and Blue Shield of Rhode Island for quite a few years, and I've also seen some other uses of these potential wellness visits that have bothered me. I think it's really important that they be integrated into primary care and really be part of it. Just sending a nurse to someone's home to rack up a bunch of diagnoses that are legitimate, I mean, so it's really appropriate risk adjustment. It doesn't necessarily contribute a lot to the continuity and promotion of the well-being of the patient. And I think one of the things that I find particularly disturbing are these type of services that might pull up to a church or a pharmacy or something like that and do totally inappropriate screenings such as electrocardiograms, carotid ultrasounds, and this type of thing. And it's completely disconnected from primary care, and yet this could be billed to Medicare, and then that locks out the primary care physician from providing the service during the year because it can only be reported once per year per beneficiary.
Yeah, and we just don't know the extent that that's happening. I mean, there's always going to be some amount of sort of, if you will, practice that occurs outside the buoys, but sometimes it gets way outside, and that's what we're trying to figure out right now.
And as in cancer care, where we say don't do a cancer screening unless you're going to be able to do an intervention if you do diagnose cancer, so too an important point that we've made throughout is really the linkage of care, the linkage of the assessment to the follow-up, the linkage of the team members to one another, the linkage of this visit and these interventions to other community-based interventions. So really tying this in with the rest of primary care and tying the annual wellness visit assessments in with other kinds of assessments and interventions with coordinated care, and oversight is critically important.
I'm really excited what's going on in Rhode Island about advanced primary care practices where we are seeing integrated behavioral health and community health care teams coming into practices. And I think, your policy recommendations are really trying to address this moving forward to things that are so important. Oftentimes, what determines health is not just medical care by a long shot, it's really those social determinants that we started out this program with. But I just like sometimes people say, what pill works best for this condition? And the answer is always, well, it's the one the patient will take matters. I think we want to be clear that although we're talking about advancing services to be more and more effective and be more integrated and coordinated amongst a variety of disciplines, we don't want to make the annual wellness exam being so perfect that nobody does it. In other words, we don't want to set such a high standard for the service that essentially nobody can meet it in the average primary care practice. And when the precursor of the annual wellness visit came about, the Welcome to Medicare exam, I remember commenting on behalf of the American Geriatric Society. And a lot of folks were trying to load up a lot of stuff that they thought was the optimal geriatric care into the requirements for the service. And my concern is that nobody's going to do it if it takes you that long. And that's the type of balance that we're trying to reach here.
And Pete, that just reminds me to raise the important issue of making it an efficient process. And one of the things that I have personally found very helpful is we have a form within our electronic medical record that guides you through the annual wellness visit and have all the resources you need, whatever cognitive screens you're going to use, depression screens. So just making it really easy and practical can also help that workflow issue, as well as, the team issues we talked about. But I totally agree. Not only is it important to make it realistic and doable, but also relevant to that individual patient.
Sherry or Brian, would you have any key messages that you would want people to take away as we're starting before we go to our Q&A? Sherry, I'll go with you.
I think this is a tremendous platform. When this started back in 2005, those of us in the public health space just saw it as a huge step forward. The American Preventative Services Task Force had been working in so many other areas for cigarette smoking diversion, other early detection programs for people under 65, that when this was codified into Medicare, it was just a great first step. And now we're seeing that, it takes time. It took us a long time in Medicare to come around to see the value of doing these types of health promotion and prevention efforts. And now it's going to take some time to get it right and get it introduced into people's lives in a way that they assign a really good value to it, and we can use it effectively, not only to improve their health outcomes over time, but also to keep our costs down in healthcare. We want to be mindful that this is a looming issue of how do we handle our Medicare funding obligations. And one way we can do that is by engaging in healthy disease prevention and health promotion.
And also providing an opportunity for the conduct of high quality evaluation research of the annual wellness visit, which would include providing opportunities for using evidence-based tools and using interventions that are also evidence-based as follow-ups to the annual wellness visit, so that we can systematically evaluate the visit and therefore provide more evidence for policymakers and others, researchers, clinicians, to improve the visit over time.
Peter, what would be your key message that you'd want people to leave with today?
Well, I'll just quickly sum it up. Things I've said. I think it's really make it work for your practice. It's a great thing for the practice. It's a great thing for your patients. And I think you'll really be very satisfied if you take the time to bring the annual wellness visit as part of your routine. And use the team if you've got it, for gosh sakes.
And Barb, how about you?
So I would totally agree. I think I personally think it's a great opportunity. With each wellness visit I do, I always just come away and thinking, wow, that was a really great way to catch up with a patient in many ways, address their issues, and look forward to how you're going to work in the coming year. But I do also agree it's critical to make it practical and doable.
So now we'll open it up to our attendees for questions. Just a reminder, you can type and send your question using the questions feature in the dashboard that's accessible on the right-hand side of your screen. We won't be using the raised hand feature today, so if you have a question, please be sure to use the questions panel. While we're waiting for some questions to come in, we are recording this session, and we will send you an access link by email once the recording is available. You can go to www.geron.org/webinar for details. So as we're looking at questions coming in, I guess one question that I saw was, Are there tools that you would use when you're trying to address cultural diversity in the annual wellness visit? Are there specific tools that you've seen that are helpful?
This is Sherry. There are tools to assess. There are tools that are in multiple languages to begin with. Many of the assessment tools have been translated into Spanish and into many other languages. So that is one way of assessing cultural diversity through linguistic diversity. And so you can look at the use of the tools in different languages. And also there are opportunities for tailoring, again, tailoring not only the tool, the assessment tool, but also the intervention approaches that follow up from the annual wellness visit, because again, the annual wellness visit is not for intervention necessarily, for tobacco control and for increasing physical activity and so on, that again have been translated and also have been studied in different populations, so the interventions are tailored to different subgroups.
Thanks. I guess one other question that came up was, around uptake and adoption. How long does it really take? Should we expect this to be taken up? We know that it's taken a little while, but how long should we really be reasonably expect? What should be our reasonable expectations?
Reasonable for a clinic to have this operational, a year would take, I would think, an adequate amount of time, probably to get it fully operational and seamless, probably 2 years. And the reason why I say that is your first 3 months, you have to evaluate the climate of the clinic itself or the health system. If you're the only person who sees the value of doing these annual wellness visits, then the sort of administrative and financial resources you need to get this going, that's going to be a challenge to acquire. I've seen some clinics, for example, integrate the annual wellness visit prompt with the electronic health records. Well, that took some doing. And so even though that's a great thing to have happen, it does take time. The second component that also takes time, and we mentioned that earlier, is just learning about the billing mechanisms that can be involved. If you're operating in a fee-for-service world, there are ways to have other practitioners in the clinic. Under Medicare rules, you can have nurses and other qualified providers who are supervised by the clinician to do these kind of wellness visits. There's also billing codes for different kinds of evaluations. Medicare just introduced billing codes for supplemental services now. So there's a lot to learn as far as setting up your practice management so that you can codify these things and get appropriately reimbursed for them. And then last, it's just working out some of the challenges clinically, as some of the folks here have reported. These visits take time. They require somebody to not just expect a 15-minute routine evaluation and management session. Well, what days are best for people to come in and do that? What sort of support do they need to get to the clinic to spend an hour with somebody? Those are all things that each individual practice needs to learn. And I think it's time well spent. So even though a year seems like a long time, I think it's well worth it.
Would anybody else have any other comments?
Yeah, I won't disagree that setting up something optimally could take a long time, and especially depending on how fast you are to implement change in an organization. But I will tell you that, and I have the advantage of participating in a lot of coding and billing activities. But Medicare provides a nice description, a nice summary of what's the required elements of the annual wellness visit. A lot of them are being done already when you see a patient annually. If you've been used to doing annual physical exams, you simply add a few more things, which frankly, a lot of people would recognize they should have been doing anyway, or in fact, they are already doing. And you're ready to go. So I don't want to minimize change in routines, how long that can take, and really setting up a great team can take longer. But you can do some of this, fairly quickly. And I don't want people to listen to the optimal and then just feel like, well, that's just too much. I'll never be able to get to that.
Yeah, I would. I'd reiterate as well. And a couple of, I think, just critically important things again is to get that template together once that's developed, and then just really kind of setting up who's going to do them. And the way we do it is we use our patient's birthday month and have we have staff that set up appointments and just set it up as a birthday gift. And so it's a way that really spreads them out over the year. So I think there are different ways to begin the implementation process rather quickly.
And one point about implementation is that nationwide, we know that implementation across practices takes quite a long time, and so the limited uptake across, or I would say the varied uptake across practices is typical for the introduction of new policy initiatives, and the gap between the introduction of the new policy initiative and the uptake in clinical practice is always somewhat lengthy. So we hope to see that trend continue to move up in uptake over time, particularly in those practices that are serving the least served members of our society.
Well, panelists, I want to thank you for just participating in this discussion today. Just to let our listeners know, two of the next issues coming up in Public Policy and Aging Report include the Older Americans Act and the Aging Network, and the use of medical cannabis among older persons. On behalf of the National Academy on an Aging Society, GSA's Nonpartisan Public Policy Institute, thank you everyone for participating. This concludes our program.